Hello and welcome to the Imedex Best of Days series. My name is Dr. Joseph Mikhael. I'm a hematologist at Mayo Clinic, and I have the privilege of serving as the chair of this series here at our Annual Hematology Meeting in San Francisco. It's a particular pleasure for me today to introduce my friend, Dr. Tomer Mark from Weill Cornell, who's joining us as we discuss issues relating to multiple myeloma here at the annual meeting. Welcome.
Thank you.
It's great to have you with us today. So, Tomer, let's get right into it. One of the challenging areas in multiple myeloma, I guess in a good way challenging because we have more options than we've ever had before, is upfront therapy. Now, historically, we've used either a bortezomib or a lenalidomide based strategy, but there's been some increasing evidence for the use of carfilzomib frontline. Can you tell us, has there been anything here presented at the meeting that adds to that evidence that might point us in the direction of whether or not we should be using this frontline?
Well, yeah, there has been some data moving carfilzomib to the front line, sort of building on the earlier data from Jakubowiak. One particularly exciting abstract was presented by Palumbo, looking at weekly dosing of carfilzomib in combination with cyclophosphamide and dexamethasone, showing very high response rates, especially with extended therapy. I believe that the people who were able to get the therapy for more than 9 cycles had a very good partial response rate and higher of greater than 75%.
Oh, impressive. So now are these people destined to go to transplant, or are these people older patients? Do you remember what was the population of patients this was used in?
I don't remember.
Okay. I think that in the sort of the classic Italian style that they provided this actually to patients in both categories. So one of the, I think, things we learned from this study was the ability to use this in older patients. Now, do you have the privilege of or the opportunity to ever use this drug weekly? Is this something that has become more common? I know it's a question we often get from the community. Of course, currently it's FDA indicated in a twice-weekly setting, but can you tell us a bit more about the weekly versus twice-weekly approach?
Well, at least in the Palumbo abstract, the weekly dosing was high at 70 milligrams per meter squared, so more than double the FDA label currently. My personal experience with giving carfilzomib in extended dosing, I have had some patients on weekly dosing, and the tolerability has been good, especially the longer they get the drug.
Yeah, and I think this is building evidence that way. I'm not sure that we're quite ready for it fully yet. It's sort of reminiscent of the early days of bortezomib. Remember,
right.
We always used to have to give bortezomib twice weekly, and now once weekly has made it more convenient for patients and actually has reduced the neuropathy. So I guess more to come on that, but that we might hear more about the weekly dosing of carfilzomib both in the relapse setting and now even in the upfront setting. Thinking still on the vein of the upfront setting, I understand that there was some work presented with one of the new oral proteasome inhibitors. Maybe you can tell us a little bit about that.
Sure. So there was a study looking at lenalidomide, Dexamethasone, and dexamethasone in combination. We all know that RVD is a very popular regimen in the United States. That's lenalidomide, bortezomib, dexamethasone. So this is swapping out the sub-Q or intravenous bortezomib with oral Dexamethasone. And in a study presented at this meeting, after a year of that combination therapy, Dexamethasone was continued as a single agent as maintenance. Turned out to be very well tolerated with a very low rate of emergent peripheral neuropathy. Most of the side effects were GI related, as you would expect with an oral drug. And the patients in this study continued to improve their response rate over time, which was reassuring for extended dosing.
So this really could herald a change in providing a completely oral regimen for patients that has both a proteasome inhibitor and an IMiD together.
Yeah, that would be a real victory for patient convenience.
So we know that ixazomib, of course, is not yet available, still undergoing clinical trial, but this could really be a step forward for us. As I understand it, it's being evaluated both in the relapse setting and in the frontline setting in several clinical trials. Well, let's shift over to maybe some of the biggest news of the meeting. Some updates, as we've seen in frontline therapy, of possibly incorporating more use of carfilzomib and maybe even a weekly dosing, hopefully with time being able to use an oral proteasome inhibitor. But let's talk a bit about relapse disease, because I think maybe the most cited abstract that's being discussed this weekend in multiple myeloma is the carfilzomib lenalidomide dex versus lenalidomide dex study, the so-called ASPIRE trial. Why don't you tell us a little bit about that, Tomer?
So it was a relatively large study of 800 patients with relapsed refractory multiple myeloma that were randomized either to KRD, which is the carfilzomib lenalidomide dexamethasone, or lenalidomide dexamethasone arm, and that was continued until disease progression. It generated some exciting data, which I believe is leading to a New England Journal of Medicine article that showed a 9-month improvement in progression-free survival. The KRD arm was around 26 months. The RD arm was around 17 months. And that benefit in progression-free survival was preserved even in patients with high-risk cytogenetics. Interestingly enough, while there were more toxicities in the KRD arm, the quality of life was reported as better.
Wow. So I imagine that speaks a little bit to being in remission.
Right.
And just on the issue of toxicities, because I know it seems to come up a lot, and one of the common questions that get asked in the community is about cardiac toxicity, in particular with carfilzomib. I think we've been able to probably mitigate most of it with careful fluid use, but was that a stronger signal in the KRD arm? Was that something that we should be concerned about, or was it pretty limited?
It was pretty limited. The rate of grade 3 or higher cardiac events was relatively low, only a few percentage points different than the lenalidomide dexamethasone. There was an increase in hypertension seen in the study, I believe around 14% for KRD. But that was a big point of the abstract, that the toxicities were manageable, and our fears about cardiac and renal toxicity may not be warranted in this sort of large study.
Yeah, that is reassuring to have such a huge study to do so. I mean, to be able to do a study of 800 patients in myeloma is always a challenge, but that is very reassuring, as I suspect that could well influence the way people are going to practice next week in clinic. That lenalidomide dexamethasone, by virtue of what you said, of a 17-month or so progression-free survival is a great combination, but being able to add another 9 months with carfilzomib is impressive. Do you anticipate that this may well change what people will do in community practice?
Absolutely. In addition to the significant impact on PFS, the fact that it can be delivered safely, yes, is a big deal, and that patients are happier on it is also a big deal.
Yeah, absolutely. Well, that's great. Well, that's wonderful news. I'm glad to hear you say that. Well, we've talked a little bit about ixazomib in the frontline setting. But we understand that there are 2 oral proteasome inhibitors that were highlighted here. I got to get all the names right. Ixazomib, which used to be called MLN9708, I think, and the other is oprozumib. Can you tell us a little bit about updates with both of those drugs in the relapse setting?
Well, I can speak to oprozumib, which was presented as an oral session at this meeting. It had pretty good single agent activity in the range of 30% in a relatively heavily pretreated population. Also very interesting is that there was single agent activity in patients who were refractory to carfilzomib.
Interesting.
Indicating, that it's a different molecule and may have a slightly different way that it enters the cell, slightly different mechanism of action.
So it's interesting, so that they even allowed recruitment of patients who were truly carfilzomib resistant. That's interesting, because we've seen that switch from bortezomib to carfilzomib, where it's not a new version of the same molecule, entirely different, but even moving to the oral formulation, there's that kind of difference. And I know that one of the concerns had been with oprozumib the amount of GI toxicity. It caused a lot of nausea and vomiting. I understand that with the newer formulation, they were seeing less of that. Was that discussed at the abstract?
It was. They talked about moving from powder in a capsule form to a tablet form. In addition to that change, there was also a protocol of adding certain antiemetics, including a substance P inhibitor that mitigated that GI side effects.
Excellent. So again, not quite ready for prime time, but the opportunity to be able to deliver a bortezomib-like drug and a carfilzomib-like drug in an oral context must be very attractive.
Well, and the single agent activity also speaks that, being active by itself, it probably will be active in combination as well.
Excellent. Well, let's stick with that theme of single agent activity for novel drugs. Another buzz, I think, around the meeting has been the monoclonal antibodies. We as myeloma doctors, I guess, would never admit that we are in any capacity behind lymphoma doctors, but we've always been looking for that monoclonal antibody that can boost the effect of traditional and even novel agents. And I'm referring, of course, initially to the anti-Cd38 molecules. Can you talk to us a little bit about that?
Sure. There's a lot of buzz about these drugs. There were several abstracts presented at this meeting involving both daratumumab and a drug from the Sanofi company that both target CD38, which is on the surface of the plasma cell as well as other hematologic malignancy cells, and can act as an ectoenzyme as well. Many purported mechanisms of actions for both of these antibodies, including ADCC, ADCP, CDC, but in the end, these both had single agent activity, first piquing our interest at earlier meetings where daratumumab was found to have a response rate as a single agent in patients with who have relapsed after 5 prior lines of chemotherapy. This meeting, I believe, is the first presentation of these drugs in combination with lenalidomide and dexamethasone, which I see as natural partners for these drugs. As we know, the IMiDs can activate T cell function,
sure.
Which is very important for antibody activity.
And so when they were combined together, were there any unusual toxicities that we should be concerned about, or were these pretty well tolerated?
Oh, they were pretty well tolerated. What was surprising to me is that there wasn't much additional toxicity other than that you would expect from lenalidomide and dexamethasone. The additional toxicity was infusional reactions mostly, and the majority were grade 1 to infusion reactions.
So the sort of things that we're kind of used to with monoclonal antibodies.
Sure. Those infusional reactions tended to occur early on, usually within the first or second cycle. Cycle 3 and beyond, they were relatively rare.
Okay, great. So do you foresee this as being a big part of what we do in myeloma in the future? Not putting you on the spot as a prophet Tomer, but what do you think? Do you think these are going to be a big part of what we do?
Sure. I think that the addition of an antibody makes sense in virtually all settings in multiple myeloma. Of course, we have to start with the relapsed refractory population, but I suspect it will soon move into the upfront as well as the maintenance setting.
In fact, I think there was an abstract, wasn't there, using one of these two. There's the daratumumab and the SAR 650984. I had to memorize those numbers.
Yeah.
Which I'm told they will have a name for soon. But even, I believe there was an upfront study with daratumumab, wasn't there?
There was. It was a study combining daratumumab with backbone therapies in multiple myeloma, including bortezomib, methylprednisone, and bortezomib, dexamethasone for upfront patients, and a subset of that was in relapsed patients in combination with pomalidomide and dexamethasone. There's some early efficacy data, but I believe there's around 6 patients in each arm, and they were focused mostly on safety. In the end, the safety signal seemed pretty good, and I believe it'll rapidly move to expansion cohorts.
Excellent. And I think that's a really important point that you make, Tomer. The ability to have a partner drug that doesn't have the overlapping toxicities that we're so used to in myeloma with myelosuppression or neuropathy. Excellent. Well, moving beyond then the oral proteasome inhibitors we've talked about. We've talked a little bit about the anti-CD38 monoclonal antibodies. There, as I see it, a lot of other ones still in line for the opportunity to be used in in relapsed multiple myeloma. Let's talk through a few of them. One of them is Elotuzumab, another monoclonal antibody. Was there some data presented here regarding Elo?
Yeah, there was. There was an update of the Elotuzumab, Lenalidomide, Dexamethasone phase 2 trial. They were looked at 2 doses initially, 10 milligrams per kilogram and 20 milligrams per kilogram. The lenalidomide and dexamethasone was given at standard dosing, what we're used to in clinic. And there was a very high response rate for this combination. Overall response was nearly 90%. Wow. And the progression-free survival in a small group of patients exceeded 20 months. So that was very exciting data and an improvement on what we would expect with just lenalidomide and dexamethasone in that population.
Excellent. So more to come on that, but
sure.
Definitely a strong signal. And then how about Panobinostat? We know that this was taken to the FDA and there wasn't an initial approval, but it's being looked at in different contexts and studied a bit more carefully. Was there data presented here about Panobinostat?
Yeah, there was. You know, Panobinostat had come with the label of having GI toxicity, causing a lot of diarrhea, and Paul Richardson, who is a lead author on the abstract, showed that the GI toxicity tended to occur earlier on in treatment, and that those patients who were able to tolerate the drug cycle 3 and beyond tended to have less GI side effects. Paul also showed that those patients able to tolerate extended dosage of Panobinostat did better with improvement in not only overall response but progression-free survival.
So would you say then the message is this molecule still has a future, maybe? Not again to put you on the prophetic block, but...
I definitely think there's a lot more data to be generated. I don't think Panobinostat is dead by any means, and it probably will have a role for myeloma. Excellent.
Well, I know that there are many other molecules that are presented. Probably one that people be familiar with because it was FDA approved for other indications is ibrutinib. Mm-hmm. Can you tell us a bit about ibrutinib in myeloma?
Yeah, there was another exciting abstract where ibrutinib was given as a single agent for relapsed myeloma. I believe the median number of prior therapies was 4. And it too had single agent activity with a clinical benefit rate of close to 50%. And the progression-free survival approached 6 months as well. So a single agent oral therapy for relapsed myeloma with a progression-free survival of 6 months definitely deserves more attention.
Excellent. So we'll probably hear more about ibrutinib with time. Mm-hmm. Well, in our last few minutes, Tomer, let's talk a little bit about maintenance strategies and then pomalidomide, an agent that we're already using. But maintenance, of course, remains a bit of a controversial area to some extent. We historically will use a fair amount of lenalidomide in patients post-transplant. Anything further from the maintenance world about lenalidomide, or I understand that there was some work presented in bortezomib maintenance.
Well, you know, it's a theme in multiple myeloma that I think is catching on, that the longer people take medication, the better they do, mm-hmm. the better their outcomes. Mm-hmm. We know that from lenalidomide post-transplant that the longer patients are on therapy, the better they do. And there was an abstract presented early at this meeting looking at lenalidomide post-transplant again and at timing of that. And it turns out that patients did benefit from lenalidomide post-transplant, and it turns out that the longer the patients took it, the better they did. In fact, the people who took it longer than 2 years did the best. Also interesting is that when people are on maintenance, responses still occur, although very slowly. The median time to complete remission, which occurred in 50% of the people who took maintenance, was 13 months.
Wow, so this idea of expecting kind of rapid, deep response right after transplant may not be there. We may have to just be a bit more patient and waiting. Mm-hmm.
Okay. Yeah, it seems more like a marathon than a sprint when it comes to maintenance.
Okay. Yeah, and as I understood too, there was some work presented similarly with bortezomib, you know, again, validating that option, especially in patients who would not be eligible for lenalidomide or have higher risk disease. Well, before we close, Tomer, maybe the last question. You know, we've talked a lot about carfilzomib, but I also understand that there has been some really interesting combinations with pomalidomide, and then some subsets of patients that are being studied more carefully with pomalidomide. But First with the combinations, are there any combinations with pomalidomide that struck your fancy here at the meeting?
Yes, there were several. There was a few abstracts about pomalidomide combinations. One was pomalidomide, bortezomib, dexamethasone, which I believe you're familiar with.
Yes.
Pomalidomide, cyclophosphamide, dexamethasone. There's an abstract from Jim Berenson, pomalidomide, liposomal doxorubicin, dexamethasone. All of which showed relatively good safety profiles. Of course, response rates were all over the place because it was different patient populations, but generally very encouraging. Pomalidomide in extended dosing was looked at in a large setting at the Stratus trial, MMO10, showing that extended dosing was relatively safe, and you could give the drug for a significant period of time. In that study, the overall response rate was around 35%. In the combination studies, response rates tended to be nearly double that, 60 to 70%.
That's impressive. So, you know, pomalidomide is an agent that's now in the hands of all of us caring for patients with myeloma. I know initially we used it with dexamethasone alone, but now it sounds like we have options to combine it with bortezomib, with carfilzomib, with cyclophosphamide, doxorubicin, and a whole series of others.
I would mention clarithromycin as well.
Absolutely. We can't forget clarithromycin for those who have taught us about clarithromycin from Weill Cornell. I think we're going to come to an end, Tomer, but I have one last question for you, which is one of the issues that comes up with pomalidomide is treating patients who have renal insufficiency. If I'm not mistaken, many of the early trials didn't include patients with a creatinine over 3. Was there any data here presented about using pomalidomide in patients with renal insufficiency?
Yeah, there was a lovely analysis of looking at pomalidomide or renal insufficiency where patients were divided into 3 groups. Those patients with normal renal function, those with moderate renal function with creatinine clearance of between 30 and 60, and those with severe renal impairment, a creatinine clearance less than 30 but not on dialysis. Basically showing very similar safety profiles across the board. So while that's sort of expected, we know that pomalidomide is mostly hepatic metabolized. It's still very reassuring for a myeloma patient population where renal insufficiency is a big problem. There is an ongoing study being done at the Blood Center in Colorado looking at pomalidomide specifically in people on dialysis. That has yet to accrue more patients, but I expect that that'll show similar results.
Great, and that'll help inform us in the future how we take care of patients with renal insufficiency. Well, thanks again so much for joining us today, Tomer.
Yeah, my pleasure.
Great to have you with us, and thank you very much for joining us in our Best of Day series here at Imedex. We trust that you've learned a little bit more about multiple myeloma today, and we look forward to seeing you on future days. Thank you again for being here.